You, we're going to be looking at exactly what it is. And indeed, we tackled this particular topic not too long ago, but we've had to come back to it because it's important. And I'll be very excited if indeed you want to be paying a lot of attention, because today we're bringing in other aspects that we haven't discussed on the show. So yes, it is Healthy You. It's brought to us by Vodafone, and then guess what? We get to open the phone line so that you can call in and ask questions. Some of you are sending in your text messages already, asking questions, and I'll pose these questions to my guests when we begin our conversation. It is Healthy You, and we begin now. I'll introduce my guests when we return. All right, so to my immediate left, I have Dr. Josephine Akbalu. She's lecturer, endocrinologist at School of Medicine and Dentistry at University of Ghana and Kolebu Teaching Hospital. And then to my far left, I have Mrs. Bridget Akrofi. She's as well principal ophthalmic nurse with special expertise in diabetic retinopathy screening. Okay, and I'm sure that for some of you, you're hearing this for the very first time. Not to worry, leave it right here, because we're going to have that discussion and all of your questions answered. You're welcome to the show, ladies.
Thank you.
And I want to begin with Dr. Akbalu. So, Doc, once again, just refresh our memories, and for first-time viewers, what is diabetes?
Okay, so diabetes is a group of conditions which is characterized by the inability of the body to process or handle glucose, or commonly referred to as sugar, properly. And it's because the body is unable to produce a chemical or hormone we call insulin, or it's produced but it's not working effectively. So in that situation, the body is not able to take up the glucose that we get from the food we eat, for it to enter the body, for it to produce the energy that we need from it. So most of it stays in the blood, and that's what we usually will call high blood glucose or high blood sugar. And that's what we use to characterize diabetes.
In my intro, I mentioned that this is a condition that is commonly described as a lifestyle, condition. What does that mean?
Well, for somebody to develop diabetes, there are generally two main aspects. Then mainly, the most common type of diabetes is type 2. So most of the time when we talk about diabetes, we're referring to type 2. Okay, so the type 2 diabetes.
That is the high risk diabetes?
Yes, so that's the one that is really related to lifestyle.
Okay. And that is the one that you would have to go on the chemos and...
Well, for all types of diabetes, you have to be on medication. Okay. Yes. But so there are four main types. So we have the type 1,
right,
which is usually found in younger people, and they need insulin. That
How
you have
young?
To give, very young, from childhood right up to young adulthood.
Oh. Okay.
Yeah, so they can have diabetes. So that's the type 1, and that's because the body doesn't produce insulin. Right. So that means treatment is insulin. The type 2, which is the majority, what most people suffer from, which about more than 90% of people have type 2. That's usually in older people, probably from 30, 40 years onwards. And in that situation, it's either you don't have enough insulin, or you have, but it's not working properly. Your body is resisting the effect of insulin. So that one is related to lifestyle in terms of acquiring it. Yes. So we have the predisposition. It may run in families, but it's not everybody who would get it. So those who would get it, usually, depending on the lifestyle they adopt, then it's likely you will manifest it. So the lifestyle will be proper diet, healthy diet,
okay,
putting on weight, and lack of exercise.
Okay, so it has everything to do with dieting
and lifestyle.
Yes, balanced dieting and all of that.
Yeah.
Okay, we'll get a bit more
right,
into that when we're looking at exactly what the best ways forward or management steps. Okay, diagnosis. Once again, how do I know that I have this condition that you've described?
So most people, for the type 1, once you get it, because they don't have the insulin, they will by all means manifest some symptoms. So they would come with urinating a lot, frequently, large volumes. They feel very thirsty, so they drink a lot of water. They lose weight. They are tired. They may even have some infection. They are prone to infections, skin infection, urinary tract infections. Or sometimes they may actually come in with an emergency where they really need to be admitted and treated. So that's the type 1. For type 2, people are walking around with type 2 diabetes and they don't have any symptoms. On the other hand, some may also come with similar symptoms like urinating a lot, increased thirst, drinking lots of water, eating a lot, maybe losing weight at the same time, infections, or they present with the complications of diabetes because it may be silent for a while. So if you don't detect it and treat it, you actually would develop the long-term complications of diabetes. So sometimes the first time somebody with type 2 diabetes comes to hospital is because they have the complication of type 2 diabetes and not just a simple one. So complications of the eye, the kidneys, the heart, stroke, and the others.
So, I mean, sometimes when I listen to professionals like yourself speak, I'm tempted to believe that probably for every slightest change, that you notice in your body, you have to see a doctor.
Yes.
Is that the case?
Yes, that's the case. I mean, we all know our bodies and we know how we function. So once you notice something that's not you, or you feel some symptoms that you usually don't experience, it's always best to contact a professional who can help you out. It may not always mean that you have a disease, but it's always good to know what's happening with your body.
Okay, I'm bringing Bridget Akrofi in a short while. She is, in the area of diabetic retinopathy screening, and she's got some demonstrations and all of that to show us. She'll be explaining as well exactly what that means. But just before I move on to you, Bridget, doc, and so I have diabetes, and you talk about sugar levels, glucose, and all of that. What should be my glucose level?
Okay. So for normal people who don't have diabetes, I don't want to say normal people, but for people who don't have diabetes, when you wake up in the morning and you haven't eaten, and we check your blood glucose level, it should not be more than, we have a value range, it should be between 4 to about 5.7.
Right.
From the one that we do at the lab or the finger prick, that's about the normal range. So anything beyond that could either be diabetes. Usually if it's more than 7, we refer to it as diabetes. Not only one occasion though, we need to repeat it. And in between the 5.7 and the 7, it's what we refer to as pre-diabetes. So you don't have the diabetes yet, but you're at very high risk of developing diabetes if you don't do something about it. But the important thing is that we need to repeat the test to ensure that that high level is persisting. Then we move on to treatment. We can also diagnose it by you've already eaten, so something we call random blood sugar. So if you've already eaten, we can still diagnose it. And when we do that and it's more than 11.1, we say you have diabetes. Yes.
Wow. All right. You mentioned that there are 4 types of diabetes. Does that include diabetic retinopathy?
Okay. So no, diabetic retinopathy is actually one of the chronic complications of diabetes.
Of diabetes.
Yes. So whether type 1 or type 2, it's a complication of the eye. Okay. So the other 2 types is the gestational diabetes, the one you get when you get pregnant. And then the 4th group is a whole list of other conditions that can predispose you to diabetes. So those are the famous.
Yes, I think we will look at gestational diabetes as well. I find that a lot of women, once they get pregnant, tend to be diagnosed with that. So we'll look at that one. But I now want to come to you, Bridget. So Bridget Akrofi, she's principal ophthalmic nurse, and she has special expertise in diabetic retinopathy screening. Explain to us exactly what it is. I mean, retinopathy, and I'm thinking something to do with the retina.
Yes.
So the
right.
eye.
Yes.
Okay.
Yes, the eye. Diabetic retinopathy is actually an eye disease that affects the retina of patients with diabetes. So if you don't have diabetes, there's no way you are going to suffer from diabetes. diabetic retinopathy, and it's usually the common cause of blindness among these patients. And I would like to talk about those who are at risk. Doctor mentioned the types. So whichever type you have, whether type 1, type 2, gestational diabetes and others, you are at risk of developing diabetic retinopathy.
Why is that?
Why is it that?
Yes,
because diabetic retinopathy usually occurs when your blood sugar level is high, and there are tiny blood vessels on the surface of the retina, and when your sugar is high, they tend to leak fluid and hemorrhages on the surface of the retina. You can just take it as a white cloth on a table where you've poured say palm oil or something on it, water on it. The surface of the cloth is no longer fighters. So when light reflects on the surface of the retina, because there are fluid there, there are hemorrhages there, you are not able to see well. So diabetic retinopathy usually give our clients blurred vision, and if you don't detect it earlier and manage it appropriately, it results in blindness.
Is there any difference with diabetic retinopathy from the other types? Considering that if you have it, yes, you're likely, to be diagnosed of the retinopathy. But
yes.
Is there any differences?
There aren't any difference.
Any differences at all?
There aren't any difference at all. Once you have the diabetes, usually it takes a longer time. You don't just say that you've been diagnosed of diabetes today, so we are likely to suffer from diabetes. Usually we have after 5 years or above. But usually if your blood sugar level is constantly high, that is when you are likely to develop it in the earlier stages of your diagnosis. So we recommend that once you
we'll come to recommendations. So
right.
What will be the signs and symptoms?
That is the most interesting aspect. Diabetic retinopathy does not give the patient any symptoms during the initial stages. What it does is it progresses and advances to the stage that management will be very difficult to save the eye. So when we get to the recommendation, I'll tell you what the client has to do if you don't want diabetic retinopathy to destroy your retina to the extent that treatment will be very difficult.
Okay, well, I want to hear from you if you have any questions for my guests. We're talking diabetes, and this is the other angle that I was speaking to. We haven't discussed it, not on this platform. And for me, this is the first time that I'm learning that if you indeed you diagnose, or if you're living with diabetes, you're likely to advance into this stage because of a few things that you've explained. There's a question though. So you say that, and that's Alex from Mankasim. Good morning, Alex. I would like to know if diabetes is curable. If no, why do the NMC, I'm thinking National Media Commission, I guess, allow some media to advertise herbal products which manufacturers claim will cure the disease? Doc, let me come to you now. Is it curable?
Well, diabetes is, I would say it's not curable. Type 1, type 2, and then for those two, they are not curable. The gestational diabetes, it comes only when the individual gets pregnant. And most of the time, once they deliver, the blood sugar levels go back to normal. It's because of the changes that take place in the woman while she's pregnant.
Meaning it happens only in women?
In women, yes.
Women
only
only.
In women who get when they get pregnant.
Right.
But once you have had gestational diabetes before, it tells us that you are at risk of developing diabetes in future. So anybody with gestational diabetes, your sugar level may have gone back to normal, but we need to follow you up because it means that later in life you may get type 2 diabetes. The other group I mentioned, the fourth group,
right?
Those ones are due to other conditions. So if you're able to, so we have some hormonal conditions that your body produces excess hormones, certain hormones which cause your blood sugar to rise. So if you're able to treat those hormonal conditions, then your sugar level will fall down. But that's a very minute percentage of individuals with diabetes, very, very small percentage. The bulk of the patients with diabetes have type 2. And as I said, 90 to 95%. And that is not curable as at now. Because what you need is the individual needs a new pancreas to produce the insulin, and also if they have a lot of weight, fat body fat, you need to get rid of all of it, which is quite impossible. So by and large, we don't advertise that diabetes is curable.
So once you're diagnosed, exactly where I was going, once you're diagnosed, you live with it, manage it.
But you can manage it, and we can manage it such that you can live a full life once it's managed properly.
So for people living with diabetes, what are those options available to them in terms of management?
For type 1, it's insulin, which is injectable, so you have to inject the insulin, various regimes for doing that.
Right.
For type 2, we have the tablets, and then we have the injectables. Okay, so for the type 2s, usually we'll start out with tablets.
Right.
And then we monitor to make sure that the tablets are working. There are various classes of tablets we can give you based on the patient you are dealing with. And we select the appropriate one. It may be 1 or 2 or 3, depending on how the control of your sugar is going. Sometimes along the line, for patients who have type 2, we need to introduce insulin.
Right.
And so insulin can be part of the treatment of type 2 as well.
Bridget, is retinopathy curable in diabetic patients? It isn't.
It isn't. We manage it, because you can't say that your sugar level will remain normal throughout your life. So anytime your sugar level goes up, it will affect your retina.
Wow.
It will affect the retina, and the tiny blood vessel in it will start leaking, and then the diabetic retinopathy start progressing.
So in this case, how do you manage it?
Yes, we have treatment for it. We have injection. That one is done by our ophthalmologist. They'll take you through laser. Laser is just a device that produces light based on electromagnetic radiation. So the ophthalmologists have the treatment for diabetic retinopathy. So for us ophthalmic nurses, we diagnose and refer to the ophthalmologist for treatment.
Okay, well, the phone lines are open now. We're just activating the phone lines. If you have any question or contribution, you can call in and share. My guests are definitely going to be giving you all the responses that you will require. So let me hear from you. As well, you can text to all our social media platforms, which includes the WhatsApp line, which remains 0246020580. Got it right this time. So it's 0246020580 for WhatsApp. Let me read one other message that has just come through. So you say that, well, please, I want to contribute to, diabetes should be tackled holistically. It is not all about medication. The major factor to consider is dieting, which I think Doctor has mentioned early on. Change your style of eating. Do a lot of fruits and vegetables, juicing to reverse the body from acidic into alkaline state, so the body will fight diseases. I'm a dietitian, you say. Let's tell people the truth. Thank you. All right, you didn't put your name to it. So this is a contribution from a dietitian. I mean, I think that right from the onset, we talk about the fact that it's a lifestyle issue and has everything to do with dieting.
Exactly.
And so you agree?
Yeah. I agree. Diet is part of diabetes treatment right from the beginning to the end. Whether you're on tablets, whether you're on insulin, diet is part of it. It's just that as much as possible, when you see the dietitian, they would tailor the diet to meet the individual.
Indeed.
But it mainly has to do with the portions, and fruits should not be eaten too much because they also
we will tackle that as well. But I have someone on the line now. I know you're calling from Tamale. What's your name, please?
I'm Yao.
Yao.
Yes.
Yes. Yeah. What's your question or contribution?
Yeah, it's a question that I have.
Please go ahead. You're live.
Okay. I'm diabetic, and I take metformin and then glimepiride. But I'm actually not. I know what the glimepiride does in my body, but I've never. I want to know what the metformin also does for me, and if it is necessary to be taking it alongside the metformin, the glimepiride.
But was this a prescription given you, or medication given you by your doctor?
Yes, it's a prescription given me by my doctor.
Okay. All right. Thank you. Doc.
Yeah, So when in the management of diabetes, as I said, diet, the medications, we have various classes. For most people, the first choice would be metformin, the medication you want to know what it does in his body. So what metformin does, it helps your body's insulin to work better.
Okay.
As we said, type 2, your insulin may not, you have the insulin, but it may not be working well. So when you take the metformin, it improves your body's response to the insulin. So it helps to bring the blood sugar down. So that's what it does. And that's the first choice for most people.
Okay. All right. Well, so you want to call in as well. Bridget.
Yeah.
How, so in reti, what?
Nopathy, diabetic retinopathy.
So in retinopathy,
yeah.
How is the diagnosis done?
We do annual eye screening.
Okay.
Studies have shown that if the damage to your retina would happen, it takes a year. So what we recommend is that at least once you've been diagnosed of diabetes, you have to examine your eyes at least once a year. At least once a year. When you come, would examine the eye, examine the retina, and see if you are started developing diabetic retinopathy. The truth is, if we detect it in its earlier stages, we are able to manage it and prevent further damage to a stage of blindness.
Wow. All right. So Dennis from Upper West says, I would like to know the pathophysiology of DP, diabetes. Yes.
Okay. So for type 1, the body doesn't produce enough, doesn't produce insulin.
Okay, so Doc, let me hold you on and go to Sunyai. Nanekia, if you can hear me, you're live.
Hello?
Yes, could you kindly turn down the volume on your set?
Yeah.
Great, kindly do that. Take it all the way down to 0. And then let's talk.
Hello?
All right, I can hear you. I think we're good to go. Hello, Nanekia? Hello? Okay, I think we lost her. All right, so you were adding.
Yes,
yeah.
So for type 1, so in the body we have an organ in the abdomen called the pancreas,
Okay.
and that produces the insulin. So those who have type 1, the cells that produce the insulin get damaged very early in life, and so they are not able to produce the insulin, the amount that they need for it to regulate the body's sugar. For type 2, usually it starts out as the body not responding properly to the insulin being produced, mostly related to weight gain. So once you have a lot of body fat, it makes your body resistant to the insulin. So initially they have a lot of insulin resistance. Insulin is not effective in the body, and that causes the pancreas to want to produce more insulin to overcome that resistance. So with time, the pancreas kind of gets tired of doing this job, and so the levels of insulin starts to drop, and then they manifest with diabetes at the time.
So that's how significant the insulin is to the body.
Yes.
All right. Let me take another call. Hello and welcome to GH Today. Your name and where you're calling from?
I'm Daniel calling from Akufo Cafe.
All right, Daniel. Go ahead. You're live.
Well, I'm a student. I've been working on diabetes for about a year now. And one problem I've seen about us as Ghanaians is that most of the time when students do research like this, people don't take interest in probably helping funding the research. I've been going around all the country looking for people to support. But I think the discussion today is a good one. Let's encourage the students who do research in that area to be able to finish their research and probably give the results out for all Ghanaians to benefit from. I think that's my humble contribution.
Okay, well, what are you studying, by the way?
Hello?
What are you studying?
I'm doing my master's in medical biochemistry, but research on diabetes. So complications, retinopathy, the nephropathy, those things I'm looking at that as well.
It's interesting that you are in the area of research, and I'd love to find out a bit more. So in the area of research, what really are those, specific things that we're looking out for in order to be able to, get persons living with the condition to live better lives?
This guy, we are looking at the gene polymorphism in diabetic patients, type 2. And that type 2, when they have the gene polymorphism, the homocysteine level goes high. And when the homocysteine goes high, it affects the eye. It affects the kidney, as your guests are talking about. So basically, we are looking at the gene polymorphism in the diabetic patients.
All right. Well, thank you so much. Hopefully, these are some of those findings that should, how do you call it? Yes, influence policy decisions around management of diabetes and all of that. I think that we have a lot more messages coming through. I have one here from Henry. Henry says, I want to know whether if my father is having diabetes, also if my father has diabetes, is it likely that I can get it too? So genetic issues.
Yes. So once you have a family history of diabetes, your risk of getting diabetes is higher than somebody who doesn't have that family history. So when somebody comes into it, we always ask, do you have the family? But if we suspect, we ask, do you have the family history of diabetes? Particularly if it's your father, your mother, a sibling, those who are very close to you. It increases your risk as compared to somebody who doesn't have.
Is there any link with blood pressure issues as well?
Yes. So most people who have type 2 diabetes usually may also have hypertension.
Right.
And it's linked to the insulin resistance I mentioned earlier, that the body is resistant to insulin. Insulin, its major work is to control the blood sugar or the blood glucose, but it also has other effects on other systems of the body.
Right.
So if you are insulin resistant, your risk of developing hypertension is also high. So there's a link.
Okay, so I'm taking another call, but Bridget, I'll find out from you exactly how that we have managed cases where persons living with the condition that have been diagnosed of, this other area have gone blind. Okay, so think about that for me. Let's go to Bolgatanga. Letitia's on the line. Letitia, good morning.
Good morning, David.
Right.
Good morning to your guest.
Okay, they've heard you. What's your question, contribution?
I would like to find out what the pregnancy man needs to do so that he doesn't get diabetes while he's pregnant. If you can throw more light on that.
Okay, so we're looking preventive measures. Yes. Letitia, thank you so much.
Yeah, so for prevention of diabetes in general, I mean, mainly has to do with lifestyle, good exercise, good diet, weight loss. So for a woman going in the reproductive age, if you are on the obese side or the fat, the risk that you develop diabetes while you are pregnant is higher.
Right.
Or if you've had it before, then the risk that the next pregnancy you get it is high. And for those who already have diabetes, before they become pregnant, we need to make sure that we call something preconception care, to make sure that they are ready for the pregnancy, so that during pregnancy they don't complicate their condition. So we need to make sure their sugars are okay, their eyes are okay, and they are actually ready. Because when the sugar is not controlled, it can affect the baby, the development of the baby in the uterus. So generally for gestational diabetes, the lifestyle, the way we prevent diabetes is the same way in which we'll prevent that.
Okay, Bridget, so before I come to you, so this person, William is reaching us from Kaneshi. William wants to know the exact figures and in terms of the glucose level. Remember I asked earlier on that if I have diabetes, what is that normal level of glucose that I should have? I think that he's talking about the fact that when he goes to check, it's usually between 4 to 6.4, and you are saying 4 to 5.7, and he wants you to throw some more light on that.
Yes, so previously it used to be up to 6.1.
Okay.
But then with time and research and others, we realized that the 6.1 cutoff is still high for you to call normal, although we will not call it diabetes. So that's how come the level has been brought down to 5.7. So normal should be up to 5.7. And between 5.7 and 7 or 6.9 is abnormal, but it's not diabetes. That's pre-diabetes.
Okay.
And then from 7 and above is diabetes. That's when you haven't eaten the fasting state. Yes. And we will have to repeat it to make sure that it's still abnormal before we think of treatment. But in the pre-diabetes, where his value falls, mostly is lifestyle, diet, exercise, weight loss.
And someone has asked my question to Bridget as well, but I have a call on the line. Let me take this call. Hello, do I have someone on the line? Hello?
Yeah, hello, Bensoa.
Yes, your name, where are you calling from?
I'm called Edem, and I'm calling from Kumasi.
Right.
Oh, I'm called Edem, and I'm calling from Kumasi.
Indeed. Edem, you're live on air. What's your contribution or question?
Okay, like, just want to talk about the management of the diabetes.
Yes, please go ahead.
Do you know something? You can just take in low refined sugar, and also you can engage yourself in taking foods highly rich in vitamins.
Okay. Yeah, I'm sure. Doc, you agree?
Well, for the sugar content, yes, I agree. Although I wouldn't, when you tell somebody they have diabetes, the first reaction would be, I don't take sugar. So it's not necessarily just sugar that would predispose you to diabetes. But what it is, if you take things that contain a lot of sugar, sugar has a lot of energy in it. But the small quantity you take is a lot of energy. And that's energy that will be converted to fat if not used. And so it predisposes you to diabetes, yes.
Okay, I'll bring Bridget in now. So, Bridget, I was asking the question. Otherwise, first of all, have we had cases where some of these patients have gone blind?
Yes.
They do?
Yes.
How do we prevent that?
Yes. So if you don't want to get blind, once you've been diagnosed of diabetes, what you have to do is once every year, let either an ophthalmic nurse or an ophthalmology examine your retina for you. If we detect that the tiny blood vessels on the surface of the retina have started leaking fluid and hemorrhages on the surface of the retina, the ophthalmologist will take you through their treatment protocols so that they stop it from progressing to a stage of blindness. So that is what we tell our patients. So I want all our patients to note that once you have diabetes, our first recommendation is your annual eye screening. It is very important because if we detect it in earlier stages, diabetic retinopathy can be prevented.
Wow.
Yes.
That's interesting. Very good education this morning.
Just to add to that,
yes,
the annual
please.
screening, not just for the eye, but annual screening for all the other complications is recommended. So as much as possible, the healthcare providers should make sure their patients go through annual screening, the eye, the kidney, and the heart and all that.
Okay, I'll take one last call and then I'll come back to wrap up. Who's on the line? Your name?
Hello?
Yes,
Yeah,
you're
Loco
live.
is my name.
Your name is?
Loco.
Okay, your contribution or question?
Yes, what do you have for diabetes cure? I'm suffering from hemorrhage. Do you have any treatment for hemorrhage? I have a diabetes and I have hypertension. Almost about 10 years now. You'll be attending hospital. A lot of the medicine we have been taking. What is the cure for diabetes?
I think Doc said early on that it's not curable.
Perpetual rest. Yes.
Okay. Okay. So thank you for the questions. Just leave it here, and Doc will give you a response. Okay. All right, Doc.
As I said earlier,
yes. So we know it's not curable.
But it's manageable.
Managing it.
Can control it. Yes. I'm not sure what he means by the hemorrhage. Hemorrhage just means you're bleeding. So I'm not sure where he's bleeding from. But if he said he had hypertension, and the combination of hypertension and diabetes usually would increase your risk for stroke. And one of the manifestations of stroke would be that they would bleed into the brain. So I'm not sure if that's the hemorrhage he's talking about.
Okay.
Yeah.
So he should be probably going back to see his health
So we need to manage,
professionals.
when you have diabetes, it comes with hypertension, it comes with cholesterol problems, it comes with blood vessel problems. So we, even though we talk a lot about the sugar, we don't focus only on the sugar when we are managing. We have to manage hypertension, manage the cholesterol problems, manage the blood problems and all that.
You mentioned as well that health professionals will have to make sure that their patients are taking through all the required procedures. It's interesting. We don't usually see that happen in Ghana. In recent times, you get a lot of the private hospitals do that. So you'll be there, you get a phone call, you have an appointment, that kind of thing. You went for maybe some examinations and lab report is ready. It's done elsewhere. Why aren't we able to make it a part of our healthcare system?
Well, I would say we are at the diabetes center. So I would say that from that point of view, we do that. So it's not, we have a schedule for our patients. So maybe we see them every 3 months or every 4 months. It's based on their control.
And they make their appointments?
Most of them.
Most of them do?
Yes. And at least once a year, we make sure that they go through the annual screening that we are talking about.
Right.
Some people may not do it, but I think by and large, most people try to. But we have to make a conscious effort. When it comes to diabetes, we should remember that the patient is the one living with the condition. He sees the doctor or the nurse maybe 20, 30 minutes in that appointment, but the rest of their life, they are by themselves or with their families. So education of the patient is very important. They should know what the disease is, what they have to do when there's a problem, and all the other things that goes with diabetes. So education is actually one of the main things that we have to do for our patients, so that they are well equipped to be able to manage the condition by themselves without the doctor when they're at home. If they have any issues, they can always come back.
Diabetic retinopathy is, I think, probably new to a lot of people.
Yes.
How much of awareness are we raising in this area?
Yes, for us at the diabetes center, that is why I'm there. We carry out mass education. So when our patients have gathered at the reception, that is my duty. Every morning I educate them on what it is, their causes, their symptoms, what they need to do to prevent blindness. So what we do is we do mass education. And then when they come to our consulting room we educate them on it. And our doctors also educate them on it. So they refer them, when you go, they ask you, this year have you screened your patient? May say yes or no. So those who say no, they will quickly refer them to the ophthalmic nurses and then treat them. So ours is mass education, because the client needs to know. If you don't tell client that your eyes will go blind, they wouldn't come to the eye clinic and examine that. Because the diabetic retinopathy doesn't give any symptoms during the initial stages. It waits till it has progressed and destroyed the surface of the retina. That is when it will tell you that you can't see, so rush. If you also detect it in advanced stage, there's little we can do to save the eye.
Okay, and it's a wrap, but it's a very important question that can't let go. We're receiving a lot of your questions and contributions. I'll forward all of them to our guests even after the segment. And this goes to you, Doc. So this one says, I was diagnosed with diabetes at age 11. I am now 28. I almost died when I was made to stop using my insulin and switch to herbal medicine. I strongly do not believe in those herbal medicines and will urge all diabetics to visit the hospital and seek proper treatment. What will be your advice, in this area, where we have all of these herbal medications, on the markets said to be curing diabetes?
Yes, so as I've said, diabetes is not curable. I know that there may be a few herbal medications that have gone through the proper process in terms of management of diabetes, but most of them haven't gone through that process. So we don't know what they contain and what they are able to do to the body aside managing your blood glucose. So it's not advisable to go and take herbal medication, that you're stopping your medication and taking the herbal medication. Most people are afraid that the drugs we give them will give them more problems. They take it for so long, so they're afraid to give them, so they don't want to continue. But our advice, whatever the doctor gives to you, you stick to that. If it's giving you any side effect, you let the doctor know. We have other alternatives to manage it, but the herbal medications, I would not advise.
Right, I know someone who will say, those doctors, not everything they tell you that is true. Sometimes you have to try the herbal medicine. Good morning, Auntie Esther. Yeah, you know yourself, I know you're watching. That's my mom, I love you. She's another doctor. in their own world. All right, Dr. Josephine Akbalu, you're a lecturer, endocrinologist. We'll have to bring you back to explain this and tell us a bit more. At the School of Medicine and Dentistry as well, University of Ghana, and the Kolebo Teaching Hospital. All right, and then Brigita Krufi, Principal Ophthalmic Nurse with special expertise in diabetic retinopathy screening. I learned something new today. How about you? Share with us. All right, the show continues with more updates.